Okay, thank you, and welcome back from your coffee break this morning. We're going to start the next session now, which is the research session. If anybody wasn't here yesterday, I'm Rachel Marsden. I'm the consultant nurse from the Care and Research Centre in Oxford, and it's my pleasure to moderate this next session for you. I'd like to start and welcome Juliette Fauché and Tommy Brunte to do their presentation. It's by INARC. It's a patient retention in ALS clinical trials, a closer look at dysarthria and FTD. Thanks, Tommy. Thank you. Hi.
So thank you, Rachel, for the introduction. I'm here together with Juliette. And yesterday, we were discussing about doing more research on people living with ALS. And today, I want to give you some closer insight how to include people and follow up people with dysarthria and frontotemporal dementia. And first, I want to talk with you about patient retention. So how do you make sure that if you include someone into your clinical trial, that that person is also remaining into the clinical trial? And therefore, it's important to develop a strategy on forehand before you start the clinical trial, how to make sure that the person living with ALS can also complete the clinical trial that he or she is in. And of course, with this disease, it can happen that there is disease progression, and therefore someone with the disease cannot come to your clinic anymore. And Juliette will give some insights on thoughts that or preparation that you can do to avoid or at least to get rid of some barriers for people living with ALS to get them into your clinic. And why is it important to think about patient retention? Actually, that starts already when you inform someone that wants to participate into your clinical trial during the reach out of the patient information leaflet, but also during the informed consent procedure, that the person living with ALS understands that the clinical trial that they want to participate in is not a treatment, but that you work together or collaborate together to find if that clinical trial that the patient is participating in might be a potential future treatment and not necessarily for that person themselves. But we do understand, and that's also what I'm explaining when I do the informed consent process with the person, that if I was at the other side on the table, I also would like to have some benefits from it myself. However, I cannot promise that if the person starts to enroll into the clinical trial. And some of the clinical trials do have like an open label extension. And even with the open label extension, we still cannot promise that the person living with ALS included into the clinical trial is actually benefited from that medicine. We do know that the person receives the actual medicine, but we still do not know whether it's effective, because that's why we do the clinical trial. Also, it's important to think about logistical aspects. I'm from quite a small country. People living in our country feel like 2 hours driving is already quite far. I know a lot of people here are from Australia, the US. I think they will call it around the corner. But it is important to have some sense about that, how about people's expectation, like is 1 hour far, is 2 hours far? Also, when you schedule the appointments, will you book them in at 8 a.m.? Or if people feel like they still need to travel quite some, that you will schedule the appointments, for example, at 11 if the clinical trial allows that. And also supportive services. There are a lot of opportunities, which Juliette will show some light on that can get rid of the barriers for people coming to your clinic. And that brings me to brings us to the preventive measures.
Great. Perfect. And I think Tommy touched on this already, but when we talk about the topic of patient retention, I think we have a tendency, especially in our investigators meeting, to really focus on the end of the trial, or once patients have been in the trial for many weeks or months already. The way we see it is that this really needs to be prepared much in advance. So first time you meet the patient in clinic or in another setting, that's where those first stones to guarantee patient retention are actually set. And so this is leading to all of the nitty-gritty of the clinical trials, because when you touch on patient retention, you really have to make sure patients will understand that they will have to come, and it's just not, you'll have to come quite often. No, you'll have to come once a week, once every 2 weeks. How do you handle all of the logistical aspects around this? And we have decided to take this talk with the spectrum of FTD and dysarthria. And this has a huge impact, and this should be discussed with patients when you meet them and you discuss about patient retention in a clinical trial. We know that around 50% of patients either present with or will develop cognitive symptoms, and this needs to be a discussion with the patients and the family members. If those symptoms arise in your disease progression, how do you think this will impact your trial participation? Are you willing to still go through this even though you will anticipate symptoms you don't even know yet? So those conversations are usually quite tough to have, especially when no symptoms are present, FTD or dysarthria symptoms. However, we encourage, when that is possible, to have those as a conversation, as a team conversation and support. When it comes to the nitty-gritty of the details, I think for patient retention that we really need to be honest and clear about potential adverse events, and this should be clearly stated to patients. So some adverse events are very common and they're expected, and some not so much, and those should be described. And for example, such as, if you fall, do you think this will impact your trial participation? Most likely, yes. If you have any sort of adverse events, what do you think you could implement in your daily life that will maintain your trial participation? And then you have to weigh in. Is it a balance within the quality of life of your patient? Is it just for the trial? And where do you put the stop? And I think you've touched on quite a lot of the other ones, so we can jump onto the FTD part of the patient retention.
Yeah, so, sorry for
No.
getting all the info on your slides. Okay.
That's it.
So as I think many of you, or not all of you, are familiar with this picture, that ALS FTD is on a spectrum, so it is not only frontotemporal dementia or only ALS, but it could be a combination of symptoms. And especially if you are including people into clinical trials, like frontotemporal dementia might not be like upfront. So I'm wondering, like, I think the majority of you are all working in diagnostic clinics. Who of you do like a cognitive assessment at diagnosis? So if you can put up fingers, so ECAS, ALS, CBS.
MMSE, MOCA.
Yeah. I see one. Okay. Two. I think, yeah. So I think the majority does do some sort of cognitive testing during the ALS clinic, but it's important to know, like, what is the outcome? And because if there is some sort of cognitive deficit or like some symptoms of frontotemporal dementia, that will eventually progress during the clinical trial. And it is important to, or even more important, to plan for that, to make a strategy for that, even more than the logistical aspects. And we put out some figures here. It's like 15% of people with ALS have like full-blown symptoms of frontotemporal dementia, but there's a way broader spectrum out there. So as Juliette mentioned, up to 50% do have some sort of frontotemporal dementia symptoms, which can influence like not coming to your clinic for follow-ups, not taking the medication that you are wanting to test, not describing the adverse events, which is not only influencing the patient safety, but also other trial participants. And clinical trial protocols do not really give us the solid criteria. They leave it up to the investigator's opinion. There's like an MMSE below 20, but not often is an ECAS, for example, performed, or a full neuropsychological assessment. And it is like phrased as like significant cognitive impairment. I think clinical trial protocols can do way better than that, than significant cognitive impairment. I mean,
It doesn't mean anything.
yeah, it gives flexibility, but it also makes it difficult. I mean, we do not want to exclude a patient because they have some symptoms of frontotemporal dementia, and I think, especially if they are not severely impacted at that very moment yet, but we know what will come, and that will influence or that might influence clinical trial participation. So I think, therefore, people who are writing these clinical trial protocols might not only say significant cognitive impairments up front, but how will that impact the clinical trial participation if they are 1 year in the trial. And then during the trial, what are the stopping rules? So one of these stopping rules is like non-compliance for whatever reason. That's not even cognitive. It could be because the patient does feel like lack of efficacy, and they meet certain criteria that they cannot participate in the trial anymore, or any situation that the investigator feels that the patient could not participate anymore. But these are hard conversations to remove someone from the trial and say, oh, sorry, you were good at the inclusion criteria, but now we feel you're not compliant anymore. That's not something we want to deliver. So that message we do not want to deliver to our patients, because people do not understand. Like, it's difficult to understand. Also, the caregivers that comes with the patient is difficult to explain to our people. So therefore, it would be it would be nice to get some more solid stopping rules, or like a plan what to do if your patient develops frontotemporal dementia that impacts the participation into the trial. And then we show a light on dysarthria.
So when it comes to patient retention and dysarthria, because dysarthria is quite often present as soon as we meet patient for the first time in clinic, it comes when, in relationship to trial participation and trial retention, as I see it as a notion of equity in access. So this is something I work on quite intensively in my PhD work, how equitable trials are for patients depending on what symptoms they present with. And when it comes to dysarthria, it does not only touch on patient retention into a clinical trial, but also patient inclusion. So for patient inclusion, we often talk about, well, the patient is not able to blow in the tube for VC, for example, so then can you use a mask? When teams are young teams or teams with new staff and they don't know those little tricks at the beginning, it really needs to be taught to them, because this can lead to bulbar patients, for example, not being considered in the same way. And this is something we see a lot. So bulbar patients are underrepresented in the trial population just because they're not considered in the same way when it comes to their dysarthria symptoms. And when it comes to patient retention, as the disease progresses and dysarthria worsen or appears for some patients, then there's a lot of alternatives that are there. We can do remote assessments by the phone. More and more outcomes and assessments are now validated over the phone. And then it comes to also patient burden to, I think, increase patient retention. How can you make it easier for your dysarthria, but also FTD patients, to stay into the trials? And this should not come from the patients. This should come from us, the community, of using those spaces like the APF, of talking with the SLP, who will talk to the neuropsychologist, who will say, oh, wait, I can actually think of a system for your dysarthric FTD patient to stay in the trial longer. However, that being said, I think we should always balance it out with the quality of life. At some point, where does it stop making sense for the patients to come? And then it's also a topic to have with pharmaceutical companies that when this line is being crossed, well, patient dropouts will exist. So all of those points need to be considered, and I think this really should be considered under the larger umbrella of equity, as I was saying earlier, both in access and in retention participation. And we'll wrap up, because Rachel is coming on the stage, with a few points for food for thoughts. And I think we wanted to ask you, by a show of hands, those 4 main points of, if you could raise your hand if you're familiar with people having FTD and or cognitive impairment symptoms, let's say, and being in a trial right now. Yeah. Okay, so minority. And maybe we'll skip the ones where they are more interactive because we're running on time. Do you think, maybe you can raise your hand if you think there should be a very clear set of guidelines for stopping rules in trial design when it comes to FTD symptoms and dysarthria? Maybe raise your hand if you think yes.
Maybe we should say, don't raise your hand if you're not agreeing.
So you see how he's changing the results. So everybody agrees. Well, we're going to leave you on those points, but I hope this gave you a clearer picture on how patient retention actually starts way earlier than when the patients are in the trial. Thank you so much.
Thank you.
I did not close it.
Thank you, Juliet. And Tommy, that's a really interesting topic, and it's a real challenge, isn't it, keeping people in, particularly with MND, in trials. I think Richard has a couple of questions for you.
Yeah, there are 2 comments that have come online, and I'm going to put them both together. So Lynn Brameyer from ALS Problem Solvers says, if cognitive issues are progressing, understanding is decreasing. Is that right? And Kevin Robinson from Neil says that regarding preventative measures, he recommends participants should have the chance to review the informed consent in their home well before the screening visit.
Do you want me to take the first one? Yeah. So I'll address the first comment. So it's a beautiful question, because that's what we all think when we start hearing about cognition. We hear cognition and you think understanding. And it's much more complex than that. And we're going to rephrase the situation, and we're going to say it's much more complex, and we're going to use this complexity for our own advantage. When you are cognitively impaired, it doesn't mean you understand less. It can mean many things. Maybe your executive function is impaired, so it's harder for you to plan. It's harder for you to, let's say, go grocery shopping without a list, and you want to make a roast. What do I need? Oh, if I don't have my list, I can't make that. It doesn't mean you don't understand your recipe of how to make a roast. It just means it's harder for you to plan it. So now let's use this and let's say, well, if we have tools, I'm thinking of ECAS, but there are other tools, that allow you to have a very clear profile of the cognition of your patient, then you know the areas of cognition where your patient is more challenged. And then you can better support your patient to go through life, clinic, trial participation. So some patients, yes, will have a difficulty of assimilating notions and making links between them, and so we would call them understanding. But this can be, we can navigate around that. And maybe other areas of cognition are impacted, and we can navigate around that too. So everything is manageable. Yeah.
Yeah, with regards to the information patient leaflet, the GCP guidelines says like patients need sufficient time to think about like whether they want to participate. So that already gives some guidance on, yes, people need to not get the patient information leaflet just 5 minutes before they come into screening. So definitely people need, we roughly provide them a week, but if we feel it's not sufficient, then we will extend that time if the screening period will allow. And we also ask them to talk with their multidisciplinary team or their general practitioner to talk it through what it means to participate into clinical trials. So that's definitely part of retention as well, rather than having patients coming in, sign, and then not knowing what they're signed up for.
And to this, I will just add that I love to recommend discussing your consent form with your family and friends, because they will come up with questions you did not even think of. So gather all of those questions in a list, come back to your study team with all of those questions, and you'll go through all of them, and you will get answers.
So thank you, Juliet and Tommy. I think you show kind of care and compassion to all your participants in the studies, so thank you so much. So next up, I'd like to invite to the stage Paul Wicks, Lainey Dredge, and Laura Webb. And we're going to be talking about expanding access to genetic education, counselling and testing, innovations in ALS genetic care.
All right. If I hit next here, yes. Okay. So hi, everyone. My name is Lainey, and before we get started, I'll just show our disclosures here. Just so you know, by my way of training, I'm a genetic counselor. My home institution is University of Pennsylvania, and I have the pleasure of consulting with some of the groups listed there. And you can see Lauren and Paul's disclosures as well. So today, we're going to take you through a little bit of background on what are the genetics of ALS and related conditions, why does genetic counseling and testing matter as part of ALS care, and talk a little bit about some innovative ways that we and others are working to try to expand access to these types of resources and services, and give some food for thought for where we can go next. So before we dive into this, I recognize that not everybody here thinks about genetics day to day the way that I do. Certainly many of us have this as a core component of our roles or our lived experience, but just wanted to give a quick refresher for those of you who might not have thought about genetics in a while. Genes are sort of what we think of as the instruction manual for the body. There's a DNA code that tells the cells how to function, and if there's a typo in this DNA code or a mutation or pathogenic variant, it can disrupt the meaning of that genetic code and cause something to go wrong in the body. And so the example here, just by changing one letter, you can see how it can change the quote-unquote meaning of the sentence, which can lead to a problem in the body. And so historically, there was this sense that ALS wasn't a genetic disease. For most people, it was sporadic, apparently sporadic, quote unquote. And so, yes, it's true that the vast majority of people who have ALS don't have a single identifiable genetic cause for their disease, but a genetic cause is much more common than we once thought. So many of you might have heard the stat that only about 10% of people with ALS have a family history of ALS or related conditions, which is absolutely true. Among those people that have a known family history, we can now identify a genetic cause in the vast majority of those people. There's still a gap, which tells us there's still probably new genes that we need to discover, new technology is needed to better capture certain genetic variants. But what people might not realize is even among those without a known family history, we are now able to detect a genetic cause in quite a few of those people. The estimates change depending on the papers that you read, and certainly will evolve over time, but at least 10% of those individuals have an identifiable genetic cause as well. And so you'll often hear us talk about family history of ALS and quote-unquote related conditions. So what the heck do we mean by that? You got a little bit of a preview in the last talk. One of the main things is frontotemporal degeneration, or FTD. But there can be overlap with FTD spectrum disorders and things like Parkinson's, for example. And so I'll tell you a little bit more about family history in a few slides. And so, again, just to reiterate that FTD and ALS exist on a spectrum. People can have symptoms of one, the other, or both. This is due to sometimes a shared genetic overlap. Certainly, there's shared pathology. If a person who is affected goes to autopsy, we can see some of the same proteins building up in the brain. And so just for those of you who may be less familiar with FTD, just wanted to give a quick refresh that as we were hearing in the last talk, it's a defect of executive function, not necessarily memory loss, which is what many people think of when they hear the word dementia. This is a condition that really causes drastic changes in behavior, personality, language, and sometimes movement, and it strikes when people are much younger than when people think of dementia, right? It's an earlier onset condition that often happens when people are in the prime of their work life, their family life, and so it can have significant impact on a person in the family. And so I just wanted to give a plug about the pitfalls of family history here. So I'm a genetic counselor, and this is one of our first tools that we pull out in the toolkit to figure out, what's the likelihood there could be a genetic cause, but it's not a perfect tool. FTD and ALS can be challenging to diagnose, and there can be misdiagnosis. So somebody could get a diagnosis of something like MS or bipolar disorder or something else that may have overlap. And there can be missed diagnoses. So especially if you go later back in the older generations, people might not have made it to the right care team, or they might have been institutionalized, for example, and they might not have ever come to the right diagnosis. Sometimes there's just limited health information in a family, whether that's because people aren't communicating, maybe there's some stigma around certain diagnoses, like FTD, for example, or maybe someone's adopted and they have no clue what's going on in their health history. There can also be, a small family size, or people may die younger of other causes like heart disease and cancer. These things also exist in the world. And so it could be the fact that a family history that appears negative could just be masked by some of these other factors. And so the other thing that I want to point out here with this image is that, sometimes people can say, I don't have family history of ALS, and therefore I don't think this is likely genetic. But if you start to then explore, there could be family history of other conditions that people might not have put together could be related to ALS, like Parkinson's or dementia. So all of this is to say that family history is an important tool, but it's not the end-all be-all when we're figuring out what's the likelihood that you could have a genetic form. And our understanding of the genetics of ALS has been exploding. There's now over 30 genes that we know can cause ALS spectrum disorders, and I love these graphs because I'm not the one who puts them together, but they're excellent. So I always encourage you to find these papers that have these great diagrams. And so many people have heard of C9orf72, SOD1, FUS, some of the ones that have been more in the spotlight because of either ongoing trials or they're more common. But there are many other genes that we know can cause ALS when there's a pathogenic or disease-causing variant, and there's more that will likely be discovered. And so the other piece to this is when you have a genetic cause found, what the heck does that mean for the family, right? And so most of the genetic forms of ALS are inherited in what we call an autosomal dominant pattern. Not all of them, but most of them. And autosomal refers to the fact that this can affect an individual of any sex, and dominant refers to the fact that only one of the two copies of the gene need to be impacted to cause the condition. And so if a parent is found to have an autosomal dominant condition, each child has a 50%, so a 1 in 2 chance to inherit that same genetic condition. What that means in terms of the likelihood of them developing symptoms depends on a different concept called penetrance. Many of the genes that we know can cause ALS do have variants with high penetrance, meaning if you have this genetic difference, there's a high likelihood symptoms will develop. But the more we study these genes, the more we're finding reduced or incomplete penetrance for some of the variants. When a genetic cause is not found, most people fall into this other bucket, what we call multifactorial inheritance, which is a fancy way of saying there's more than one factor that influences why disease develops. And so if you take a look at this jar model, if you have to fill the jar up to get ALS, we're all born with some inherent genetic risk factors we probably can't even measure yet. And those are those little small yellow balls. Maybe someone's born with this bigger yellow ball, a slightly higher genetic risk factor, but that alone is still not enough to fill the jar to cause ALS. Maybe we've got environmental exposures, trauma to the body, these other blue factors in there. And so the question is, how many factors does it take and what are those factors to cause ALS? And so many people fall in this bucket where we just don't know. There's a lot of good research going on in that space, though. And so when we talk about genetic testing, I like to broadly categorize this into two main types. The first is diagnostic, and the second is predictive. Diagnostic genetic testing refers to the process of testing a person who's already developed ALS or symptoms of ALS and trying to do testing to understand why that's developed. And often that's the first place we start in a family wherever possible. Because if you can figure out the genetic cause of a person's ALS in the family, then other family members can decide if predictive genetic testing is right for them. With predictive genetic testing being the process of testing a currently unaffected individual looking to see if they've inherited risk to develop this condition in the future, which is a highly, highly personal choice, and we'll come back to that. And so I highlighted the diagnostic genetic testing piece there, not just because it's often where we start, but also because I think that's where most of the attention has been lately in the literature. There's been a big push on the importance of offering genetic counseling and testing to all persons with ALS, particularly in the United States. We just had a guidelines paper published by my colleague Jennifer Rogenbach, who's going to speak later on at the symposium on the guidelines that were published. So if you stick around, check out her talk. She's fantastic. But basically, there's been work that's shown that, because family history is a limited tool, and you can have a genetic form of ALS regardless of whether you have family history or not, and because a genetic diagnosis can have benefits to the person diagnosed and to the family, it's important that everybody is at least offered this service. And so not everybody might want it, but certainly it should be offered. And so genetic counselors are a limited resource, as we'll talk about later, and we need to think about not just how genetic counselors can be offering this to everybody, but how clinicians like neurologists or nurses can also integrate talking about genetics into part of their care. And so these are just a couple screenshots from Jennifer Rogenbach's paper on the guidelines, showing some of the genes we feel are important that all persons with ALS should have the ability to have tested, and some of the key counseling highlights. But you check out her paper or her presentation for more. I also want to point out that, when we talk about what genes are the most common in ALS and things like this, a lot of the research has been done mostly in European white populations, and we are in a global meeting right now. So I think it's really important, especially here, but in general, to call attention to the fact that there is diversity in the geographic sort of spread of genetic variants that can cause ALS. And we still have a heck of a lot to learn about, what are some of the more common variants in these understudied groups. And that has implications not just for the diagnosis and for the, care of the person and their family, but it's going to become incredibly important as more trials are developed. And where are we allocating funding for some of these these gene-targeted therapies? Are they only going to these more studied variants, and are those more studied variants, unique to a certain population? And it's important, that we recognize that genomic medicine is not just a thing of the future. It is here. And the top of the screen, you'll see my colleague from Penn, Dr. Colin Quinn, administering tofersen, which is a now approved therapy by the FDA in the United States. There has been a huge increase in the amount of gene-targeted drugs, not just, in the neurologic space, but more broadly. And hopefully there's more to come. And so I think it's important that we recognize that increasing access to genetic counseling and testing is now even more important, given the fact that this can have treatment implications for people. But there's more to a genetic diagnosis beyond treatment. And so for some people, getting an answer as to why they have developed their condition is in itself a huge relief, just to know, to have that answer as to why. It can end a diagnostic odyssey. We all know here that ALS can be incredibly difficult to diagnose. It can take years of doctor's appointments and invasive and costly procedures. And so if we can, shorten that process, why not? It can provide anticipatory guidance for the person diagnosed, what to expect in the future. Is this a genetic form that's also linked to FTD or Parkinson's or other symptoms? It can help us hone our access to more appropriate support, research, advocacy resources that are more targeted. And really importantly, this can also inform the family. And so, I had mentioned before, predictive genetic testing is something some people may consider, whether they want to know their risk status. We can't do that for a person and a family really accurately unless we've found a genetic diagnosis. We can use family history to give us a guess, but having a genetic diagnosis in the family can really hone that risk. And it is a highly personal choice whether someone wants to undergo predictive testing, and it should really only be done in the context of genetic counseling because there are emotional, practical, legal, logistical considerations to be made here. People need to have the time and space to think through, first of all, am I comfortable having this information in my medical record? There are laws in the United States that have some protections, the Genetic Information Non-Discrimination Act, for example, but there are limitations. So that law does not protect against discrimination based on your genetics for your life, long-term care, or disability insurance. And there's similar protections and things in some states, and this may differ globally as well. There's a couple of papers out of Miami's group, Dr. Benatar has, with some information about other countries as well, which I apologize for not summarizing here. But people have to ask themselves, do I want to know this information? What will I do with this information? Is it going to make me anxious? Is it going to make me empowered? Am I going to use this to make different decisions about planning for my future, whether that's my career, my retirement, how close I want to be to my family? Is it going to change my reproductive planning or not? There are some technologies that exist to try to avoid passing down a genetic difference in a family. None of them are perfect solutions. None of them are cheap. None of them are easy. But these are things that people weigh among many other things when they decide, is this right for them? And so I mentioned the importance of genetic counseling. Obviously, I'm biased. I told you I'm a genetic counselor. But I think it's really, really important that we make sure people have access to this service if they want it, especially when they're undergoing the predictive consideration. And so genetic counseling really is a process of helping people adapt to this medical, psychological, and the informational needs related to a condition in the family. And so as I mentioned, we take family history. We use this to help us figure out what's the likelihood of a genetic cause. And then we help, figure out, is there the most appropriate test? Do you want to pursue this? Help you make the best decision based on your needs and your goals. But genetic counselors are a limited resource, as I mentioned, with growing demand, especially now with the increased treatment and things like this, or genetics-focused treatments. And access to this service really differs based on where you're located, which seems to be a common theme for the conference. And so we really need new approaches to streamline this service and to make sure people have not just access, but equitable access. As I mentioned that this is only going to continue to worsen a gap in access to appropriate care and treatment. And so today, we want to talk to you a little bit about some innovative ways that we're trying to address the gaps in care. So first, I'm going to turn it over to Lauren to tell you a little bit about the Les Turner ALS Foundation Decision Tool.
Thank you so much, Lainey. That was a phenomenal presentation, a nice recap, so we can talk a little bit more. I'm Lauren Webb. I'm the Chief Advocacy and Outreach Officer for the Les Turner ALS Foundation. Our foundation's been around 46 years, and we actually funded the SOD1 research and looking at that, and that was an area that we heavily focused on. We fund research, we fund clinical care, and we have a support services team who does direct service. So we talked a little bit at our roundtables about what keeps you up at night. Well, genetics. Access to genetic counseling keeps me up at night. I've been thinking about this issue for over 20 years, and it took a trip to Perth, Australia to find out about the work that they were doing there around shared decision making. And at that conference in 2019, I learned from our colleagues, Ann Hogden and Ashley Crook, about their tools that they were utilizing. I learned about a whole entire community around shared decision making. And we talked through about what could that look like within the genetic space. And during all these international meetings that you sit in on and you hear these little stories and these about research and what's coming down the pike, and we gleaned and we understood that there was a change in practice that was happening in the United States, a clear change in practice. It used to be that physicians would only offer genetic testing if you had a family history. Well, Jennifer Rogenbuck, who Lainey talked about, worked together with a large working group to come up with these processes and ways to think about genetic testing. And so we knew that was coming, and so we decided we're going to take the decision tool and help address the issue of not having enough access to genetic counselors and being able to provide people with information that they can read in their own homes, digest it, think about it, and really bring it to a conversation with their healthcare team. Again, the whole purpose of shared decision-making tools is to simplify the information. We don't go into a lot of numbers. We don't talk about penetrance. We don't go into all those levels of details, which will happen when you're talking with your genetic counselor, depending upon your specific interest. But then we also focused on gauging a person's understanding. We had interactive components around decision-making. We wanted to make sure that we clarified their preference. What matters most to you? And that was really important. And then we also, I don't know if this is actually true, but I'm just throwing there on the slide to be quite honest, but we do know from other literature that utilizes shared decision-making tools in other disease states that does help improve health inequities. It's clear. And we also know that when you look at maps, we had a nice presentation on maps, but when you look at health literacy maps across the US, and I can hone in to where I live in Chicago, and I can tell you which neighborhoods have a low level of health literacy. And they also have, we've been talking about zip codes and the zip code lottery. And for some people, it's very challenging, and those accesses to social determinants of health. So if you can't even get in to see a primary care physician, you can't get to a multidisciplinary clinic, how are you ever going to have a conversation about genetics? And so we really set off at the foundation on a journey of looking at health literacy and shared decision-making to improve the quality of life for people living with ALS, and we wanted to facilitate conversations. So on May 1st, we launched our genetic decision tool, which is the first of its kind in the US, to help people make informed decisions about their care. And this was really important for us. We started off, the first person I called was Jean, who's in the room here, who has presented, and said, we have this idea, what do you think? And so then from there, we started talking with more and more people in the community. We did informal interviews with them and kind of work through, and then we also went to the literature to better understand what is the current practice, what do we need to think about, and that's how we move forward. And we involved people living with ALS to do user testing, as well as help us with the writing of the copy. And what was critical through this user testing, which I'm not going to belabor today because that's a whole nother talk, but people were not aware that ALS had cognitive involvement. And I think that's really important. We did, from our socialization or our testing with other colleagues, we learned from a caregiver living with ALS who said, whoa, 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 you're giving too much information about FTD. Why don't you just focus on the basics? And we revised that because people are trying to digest a lot of information. We gave them a wee snippet, and so that they understood that this is a possibility. And so again, the whole purpose of the decision tool is to really walk through some of those things that Lainey talked about. So we walk through the benefits and the emotional challenges in a very neutral language, because everyone has different reactions to genetic testing, and we wanted to allow for them to work through their choices. So please, I encourage you to scan the QR code, take a look for yourself, walk through the tool. We've had over 900 views of the tool so far since May, and I think it's really, I would implore you, my take home for you is to log on and to take a look at it and to let your multidisciplinary clinic teams know that this is a service that's available for them, because not all multidisciplinary clinics have genetic counselors. So our current modules for the decision tool, just to promote it actually, but to kind of tie the conversations that we've been having today around non-invasive ventilation. So we have a decision tool for that where people can click on, again, focus on what matters most to them, and the feeding tube. We do have hospice and palliative care organizations that we work with that actually walk through the tool with the people that they're working with to help drive those conversations. And coming in 2024, we're working on genetic testing for people at risk of developing ALS. And so, more to come later with that. And we're also working with, you heard from Allison yesterday about the clinical research learning ambassadors in the States. We're working with her and her team to help simplify clinical trials and to ensure that people have an understanding of what is clinical research and how they can participate. So we're going to be working on that, and we're going to develop a decision tool around that. And so I just wanted to highlight a couple other educational materials that we have. Lainey is going to be speaking at our ALS Learning Series, which is a webinar that we have in January. And she's going to be giving a talk called Conversation with Genetic Counselors. Could the ALS in my family be genetic? And so this is a patient-facing webinar. So I would encourage you, if you have families and you want to introduce that topic to them. We also have Jennifer Rogenbuch's, if you're not sticking around for the larger scientific meeting, we have Jennifer Rogenbuch's talk where she talks about the standard of care around genetic testing and the new options. And then we also have on our ALS Learning Series a talk from a few years ago, which will need to be updated, but it's still good, around family planning from Lisa Kinsley at Northwestern University. So because Casaldi wasn't a thing at that time. So I would encourage you to take a look at this information, and it is an honor and a privilege to be able to work with families to co-produce with them the things that they need at the right time, and that's what the Les Turner ALS Foundation is committed to doing, and that's what this community is committed to doing, and we can only do that by working with each other and learning from each other. So thank you.
Thanks, Lauren. So my name's Paul Wicks. I'm a neuropsychologist, and so it's been music to my ears hearing some parts of the last couple of conversations that we need to have more understanding about FTD and cognitive dysfunction, but it's also still quite sad how many people aren't being told. And my story with ALS actually goes back 20 years now, when in 2002 I started as part of my PhD at King's College London researching cognitive dysfunctioning and neuroimaging in both sporadic ALS and also people who carried a SOD1 mutation. And back then it took me about 3 years just to find 7 people with a SOD1 mutation in the whole country. So you can imagine how challenging that was. But at the time, there was a lot of denial that cognitive dysfunction could be an issue. So I spent a long time working on that. And then I moved more into digital technology, worked at a company called Patients Like Me for a number of years, which hosted large online communities for ALS. But my position in this field changed a little while ago, and I've gone from carrying a researcher passport to also having a caregiver passport. So this is my father-in-law. 10 years ago, he was diagnosed with a very slowly progressive form of ALS by some of my friends, by some people I've done karaoke with in Yokohama, which puts you on the other side of the table and is very unusual. We've been very fortunate to be supported by a wonderful care team. But, I want to acknowledge that, as a clinician, a clinical researcher who had read every piece of paper about ALS up until this point, I thought I knew something about ALS. Turned out I didn't. So that's my eldest daughter, and you can see her neurogenesis in contrast to his neurodegeneration. He is currently less than a 10 on the FRS, but you can see he does have some residual function to make sure he has a glass of whiskey to hand at all times, which seems to be underutilized as a mechanism. So when we went through this process, we did have the opportunity to undergo some genetic testing as research to see if he might be eligible for one of the studies that was coming through at the time. And clearly we were very well supported by an excellent team, and the fact that I knew a fair bit about this was a help. We were very fortunate in that of the genes that he was tested for, he was negative. But it took a few months for those results to come through. And so I knew in excruciating detail the size and shape and weight of that sword of Damocles hanging over my family. And I think there was a clear choice we had when we tested negative to either go, phew, thank goodness for that, we've dodged a bullet. But particularly as I was locked away in my shed during COVID, it occurred to me the great unfairness and the unjustness of, well, what if you can't text Martin Turner on WhatsApp to find out what we should do next? What if you don't speak English as your first language? What if genetic testing isn't widely available? And so I started looking to some of the tools I'd used in the past of using digital technologies, of working with patient advocates to say, okay, what is a system that we could develop that could be more equitable, that could scale to more people, so that if you were in situations like this in the future, that everyone would have a more equitable shake at better care. So we started, as you always should, by talking to the people most affected, so by people who have ALS, who have symptoms of ALS, or people who are at risk of genetic ALS. When I started research in the field, there wasn't even a good term for people who carried the gene. The word pre-symptomatic was still used, which I think is highly problematic as it sounds deterministic. But as we started speaking to people, a very consistent pattern came from both the scientific literature and from talking to people, whether in group settings or individually, that there were a great deal of fears, that there were some really significant burdens. Work that Christiana Salmon has done in places like Canada show that even in a developed economy, you could have a different answer if you see a different clinician in the same hospital. So it's not just a zip code lottery, it's a clinic room lottery. That shouldn't stand, that mustn't stand. Clearly, experts have expertise, but you only see them for about an hour a year. And who else is there in that part in between? So my experience in patients like me was that, at 2 a.m. in the morning, it's other people like you. It's other people who have been there, done that, worn the T-shirt, walked a mile in your shoes, had that awkward conversation, had an awkward Thanksgiving where you're disclosing your genetic status and maybe someone at the table doesn't want to, or is angry that you did, or complex conversations about family planning that clearly can be very emotive, but shouldn't be suppressed. So as these sort of came through, we sort of thought, well, clearly we'll never be able to solve all of these, but what we might be able to do is to develop systematic means to plug some of these gaps. We did have a careful look in the scientific and clinical literature. We've been very well supported by a scientific advisory board to sort of check, when there is good care in place, how consistent is it? And I think Jennifer Rogenbach's work is so important to illustrate that there's a great deal of inconsistency in the space about who is offered testing, which genes we test. So this heat map, for example, if every country was consistent, these would all be red. And it just sort of shows that different tests were available at different times. It's slightly out of date, but I imagine that the principle still holds. Genetic counselling is so important, and we've heard anecdotally of in the UK we've got 18-month waiting lists in some cases for genetic testing. Genetic counselling could be a 5-minute phone conversation, and we've heard all sorts of horror stories, frankly, about how people receive their results. People got voicemails. People got text messages. People got a nurse calling them up saying, "Good news, it's positive." It's a disaster. And, I think so much more needs to be done and could be done better. So the solution we've attempted to put out there for some of this is called Light the Way. And the aim is to sort of light the way through the darkness that the people find themselves in, through a variety of things. So for one thing, from genetic education, this stuff is complicated, very complicated, and the more you look into it, the more complicated it gets. So we have a series of videos and modules that Lainey has produced and is the star of the show in, to ensure that people have a good grounding, a good understanding, no matter at what point they've come to this. We're going to connect them to peer support. You're probably aware of End the Legacy, who have weekly drop-in calls for research and advocacy, but they also have monthly groups run by social workers to deal with so much of the mental health issues that go into this, the emotional work that needs to be worked through here, and the understanding that you can only get from other peers. Family planning is so crucial, and in part this work was inspired by someone called Daniel Barvin, who's been very public about him and his wife's journey with IVF. And that baby picture of his cute little baby is really one of the targets that we're aiming for, that for those people for whom it's suitable, for those people where it's appropriate, we want to make sure people have got all the information. Genetic counselling should not and must not be restricted to luck of the draw and what have you. And also we want to make sure that was available both pre-test to understand if you want or need testing, and post-test. Even many people who we speak to who are in studies, who've seen their results, haven't fully got all the information, aren't fully able to convey that to their family members, and that's a real gap. Genetic testing should be possible at home. It's quite easy now to send kits in the post. I mean, if you've had 23andMe and you've spat in a tube, it's a very similar technology, right? We don't necessarily need to bring people into hospital, scary setting, blood draw, all the rest of it. It's so important to connect people to research studies. If we don't know if someone's got the gene, we can't put them in the trials. We can't put them in the observational registries. We can't put them in DARS and PREFALS and ACORN and the C9 trial we're discussing in 2 hours, right? All these types of things are only possible if we have systematic screening, systematic surveillance of all these things. And then, of course, in the US, we have a gene therapy. And, I hope that becomes more widely available at other places. But one can only imagine if you don't happen to live near Boston, near San Francisco, and you weren't tested, then, time is neuron here. If we can't find people that are eligible for these therapies, we are wasting whole generations of folks' time that could really be treated. We also knew from the get-go that this could be multinational. You know, Facebook and Uber and all the software that you use works in multiple countries if it's coded from the get-go to work that way. So we've developed Light the Way for the UK and the US initially, and in the US it's going to be available in both English and US Spanish, because one of the inequities that I think Lainey mentioned must be about health equality and language. So the way it'll work is everybody's going to have access to these education and peer support modules. If they decide that they would like to go ahead with genetic testing, everybody's going to get pre-test counselling. That will be delivered sort of by video conference. They'll have their spit kit delivered to them at home if they decide to go ahead with that, and then the results should come back. We're hoping much, much quicker than we get, certainly in the NHS. Just to say, it's a research use only test for the initial screen. If it turns out to be positive, we will also be double running it through a clinically validated, clear, compliant test, so that the results that come back to the person will be clinically actionable if they ever give it to their care team. And the return of those results will come from a genetic counsellor, nearly always the same genetic counsellor who did that pre-test training. So this is not an email, this is not a text message. Clearly, if people are negative, like our family was, there's some degree of relief they can get from that. It doesn't mean they're necessarily 100% out of the clear. And clearly these people may have survivor's guilt. Many of them will be caregivers to brothers, nephews, cousins, etc. Right? So I think they're still part of our community. They're still a really important resource for us all. If they're positive, we want to make sure they're plugged into trials, studies. If there's a therapy available for them in their country at the time, we want to make sure they have access to those. And so we want to make the point that there's a lot that can be done. Some people will have a variant of unknown significance. We want to engage those folk as well and make sure we can continue to work with them. So this is launching now, and we're going to be here all week. We have a booth at the main conference. It's bright orange, so you probably can't miss it. But we also just don't want to say this is a thing we're trying. We also want to study how we're doing as we go through it. So as part of a research study, we're going to be looking at the anxiety, the depression, the sort of fear of the stress, mapping out this sort of Damocles feeling as people come in at baseline, but also 3, 6, and 9 months later, as we compare different cohorts that are untested, that are positive, that are negative, or that are uncertain. And the reason for that is part of this variation that I hear comes from individual clinicians and teams and their personal beliefs. If it was me, I wouldn't get tested. Okay, that's fine for you. That doesn't necessarily mean you can generalize that to everybody. And one of the fears is, well, if we told these people, of course, they'd all be incredibly depressed and might have suicidal ideation. That would be a net worse thing. Well, we need the data. We can't just assume that that's the case. And so this study, the Beacon study, is intended to gather that data, to feed that back to groups like the genetic counsellors to actually see, because we know in BRCA, we know in Huntington's, clearly when people do get very distressing news, that's a very difficult situation for them. But over time, they incorporate that into their narrative of their life and they make decisions. The vast majority of people surveyed on this do not regret having found out the results of genetic tests, but we want to continue to check if that is the case through these cohorts, and that's something we'll be doing. So what does success look like for us? Well, this is initially funded by a grant from the UK government. We're able to hopefully educate about 1,000 people across both countries. We're looking for about 150 people to get the genetic testing. But we're really hoping that this sort of program will not just let people know about the results, but actually empower them, inform them, help their families to understand what this really means for them. Clearly, we couldn't do this alone. We've had fantastic support. We're so lucky to have a scientific and patient advisory board that are really some of the leaders in the world on this. We work very closely with End the Legacy. And this technology is made possible by a group of free-range geniuses out of Cambridge University called Sanogenetics, who have made all the technology possible. So, yeah, we're hopeful this is an initial approach and will inspire other people to try other innovations and other approaches wherever they may be. Thank you.
Okay, just 2 quick slides before we go to questions. So we would be remiss to not put up some additional resources for genetics specifically in ALS FTD, some of which have been highlighted along the way, but I'm stalling here, so if you want to take photos, get your phones out now while I'm still killing time, letting you look at this slide. I will also put in a plug for this slide. You see the Penn Familial FTD ALS Conference. That's my baby, my pet project. We've now done this this will be our 4th year. We're going to have our 4th conference in February, so save that link if you want to save the date for that. And also a special shout out to End the Legacy, which we have highlighted throughout here, the first group dedicated to genetics and people who are at genetics risk. So everyone, round of applause for End the Legacy. Yes, doing the good work. Okay, and so where do we go from here? We've spent a lot of time highlighting some of the problems with access and some of the solutions that I'm really proud of my colleagues for working on. This has been some incredible work. But some other things we wanted to highlight is in the US specifically, genetic counselors are not Medicare recognized providers, which has a huge impact on people's ability to access us as providers. So if you are part of institutions that do lobbying or policy and you want to advocate for your institutions to sign on to those policies, please let me know. Please go do that. And both in the US and globally, there's other things we can do. We need to continue to spread awareness, both through advocacy groups, but through clinical care teams and things like this. Alternative service delivery models still need to be developed, so how else can we streamline this care? We need to work on translating these resources that have been developed. And we need to make sure that research opportunities are given to people of all backgrounds. And I'm on my tippy toes here. I think that was my last slide. Okay, and so with that, here's some references. I'm always happy to share those slides. Thank you so much for your attention, and we're happy to take any questions.
Lainey, Lauren, and Paul, thank you so much for a fantastic session. This could have gone on all day. I have a lot of comments and questions, but I haven't got time for any of those. And everybody in the room can catch them around for the rest of the day. But we do have one quick, hopefully very quick question from Richard online, I think.
There were 2 comments, and I'm going to put them both together. From Lynn at ALS Problem Solvers, she said, one of my genetic tests had an asterisk. It was different from the norm, but bravely proclaimed as non-pathogenic. My doctor dismissed it, so I didn't get counselling. 3 years after my test, I have not found any information about my specific typo. How often does this occur? And the second point is about ethics from Rachel Thompson at Brighton Sussex Medical School. Just had a look at the tool, which looks great. I would love to have something similar in the UK, as some of the info is different, especially the time taken for results. One thing that worries me is how ethical it is to offer testing to someone when they may not live to see the results. The current wait in the UK NHS is 12 to 18 months.
So neither of those are quick.
Yeah.
But
I can be as quick as possible. So regarding the typo or variant without a ton of information, if it's called non-pathogenic or benign, likely benign, versus if it's called variant of uncertain significance or VUS, those are different things. But there are many people who receive these variants of uncertain significance or VUSs, and many of them are unique to that person. They might not have been reported in the literature before. There might not be any information to learn about it. It is common. It is something that a genetic counselor or a genetics trained expert can help guide you through. Sometimes there's follow-up steps you can take to try to clarify the uncertain variant, like testing other affected relatives if they exist, if anyone else was affected and they're living, or doing follow-up functional studies or literature reviews, things like that. But sometimes they remain uncertain for a long time. And sometimes we can use what we do know to say, this is uncertain, but we're less suspicious of it, or this is uncertain, but we feel that this actually could be causal and we're going to keep an eye on it. And so that's my take on VUSs. And then in terms of the ethics of testing when someone may not be alive to learn the results, that's a heavy hitter. That's a tough question. I think that, so in the US, most results, if you order clinical testing, typically results are back within about a month. So, certainly people can progress that quickly, but, with wait times before you can even get testing, that process can lengthen. I would say even if the person may not live to see the results, there could still be benefits to the family in getting that information. And so that's why it's really important before a test is ordered, you talk about the potential impacts of the type of results, both for the person diagnosed and for their relatives, and you partner with them. Who are we allowed to disclose this information to? Because they might say, if I'm no longer living, I still want my spouse or my adult child to have this information. So certainly the number one fix would be to speed up the testing process, and really that means speeding up the initiation of the testing, not really the test itself, but when you start that process, but also being conscious even from the get-go of who are you able to share this information with on the back end.
All three of you. Sorry. Next up, I'd like to invite Tommy and Juliette back onto the stage with Peter Amboul, who will be talking about the international patient inclusion in ALS trials.
So first of all, we are pretty happy that Peter is not traveling to our site, but I'm traveling to Peter's country. While Peter is coming up, Peter is one of the patients that I'm seeing. He travels, in the beginning, he traveled every week from Switzerland into our clinic to participate in one of the genetic trials. And we want to show some light on that perspective, like how it's done. So you will hear the perspective from myself as a clinician, seeing people in clinical trials, Juliette in preparation, so the Swedish perspective, and Peter's perspective, how it is from a person living with ALS to travel from country to country and participate in a clinical trial.
Great. International patient inclusion should be the gold standard in ALS trials. That could be the whole extent of the talk. And if at the end of the talk, this is what you're convinced on, then we won. And maybe we'll start by, what does it mean, international patient inclusion? Well, that just means you're doing a trial in a country, country A, and you're going to include a patient coming from country B into your trial. And many reasons can motivate that. And this is something that not all sites offer. There are some barriers onto the why that is the case, but there are also many solutions to make it work. And this is what we will present to you today. The why is that there's a huge inequity in access in ALS trials today. So I'm going to walk you through the context I'm currently the most familiar with, just because I'm based in Stockholm, Sweden, working at the Karolinska Institutet. So we are the largest ALS clinic in the country, also the largest ALS site in terms of clinical trial. So this is a very privileged position to be in, and this is not representative of the Nordic countries or Scandinavia. If we look at the map quickly, those numbers, I collected this a year and a half ago, so they have changed a bit, but this is still the same kind of scale we're talking about. There's no ALS trial in Iceland. There's 11 sites in Norway, but they were all doing the same trial. So there's one trial in Norway. Finland, one trial site. Denmark, one trial site. Sweden, 4, but mainly 2 very active. How many clinical trials did they do? 0 in Iceland, 1 in Norway. Finland, 1 at that one site. Denmark, 1. Sweden, at that time, 11. That means that you could be a Finnish patient and you don't qualify for the one trial Finland has to offer to you. And we are like 30 minutes away from you by plane. We are doing 11 clinical trials, but you can't be in because international patient inclusion is not the standard yet. And here I'm talking about a sporadic patient who's eligible for most of the clinical trials that are out there. But when you start talking about precision medicine, targeted ALS clinical trials, we see this as becoming even more unfair. Oop, yeah, you're going to jump into that after. We see this into becoming more unfair because you could have the chance to be considered for a targeted trial for your targeted mutation, but it's not offered in your home country, and it's not made easy for you to travel to another site. So this is raising a lot of questions, both on ethics that we'll dig into, but also on how fair is it to be considered differently depending on your home country and depending on what is offered in your home country. So we're going to present to you data specifically on genetic trials, and then we'll jump back into those ethical considerations.
I think this will bring into practice like the previous talk where if you have someone living with ALS has a genetic mutation, and there are currently trials offered, but they are not offered into every country. So here I present you a list of trials that were active in 2023. Not all trials are active anymore. So the trial, the second last trial from Wave 004 is not active anymore, but especially I think the ION 363, so the FAST trial is running in a couple of sites in the US and also in Europe, and as we all know, these patients are pretty rare. So it is important if you are a clinical trial site that you provide access not only to people in your own country, but also to people from foreign countries where the trial is not running. And that also accounts for ATXN2, where only 2 trial sites were present, us in Utrecht and one site in Turin. And as Juliette mentioned, to offer a trial for every person with this genetic mutation, it should not only be limited to Dutch and Italian patients, but also to other people in Europe. And that will we talk about later with Peter. And Juliette will show you some more insight into the ethical aspects.
And now I realize we have a screen here that's working, so yeah, I can stop doing this. So when you look at ethical literature, research-wise, you discover all of those notions about vulnerability. What does it mean to be a vulnerable patient population? And ALS qualifies at this because as an ALS patient, because there's no cure, you're vulnerable to accepting risky research. You're vulnerable to not benefit from the research that will be offered to you. So for those reasons, it becomes a huge duty for the research and clinic population and community to kind of serve the ALS patient population and community. And we see this ethical duty and responsibility as the major driving force to allowing international patient inclusion for clinical trials. And then this really brings this area of targeted versus non-targeted treatment trials. I know this will be the subject of one of the talks for a plenary session at the ALS-MND later this week. And should we, and this is a question I'm also asking you as a reflection point, should we make it standard for the targeted clinical trials that consider genetic mutations to all include international patient population and allow for this transfer and for pharma companies to support traveling of patients from one site to another, specifically for targeted clinical trials? Wasn't it you talking about? Yeah, it's you talking about practicalities.
We are advocating for international patient inclusion, but there are major practicalities that needs to be arranged upfront before you are capable to host someone from another country into your country. I will go over these points, but what I want to like with my knowledge now, like we started 1.5 years ago with the first person from abroad, is that a person living with ALS, whether they're from Germany, Switzerland, Netherlands, it is still a person with ALS. So it might be frightening that you not speak the same language. The healthcare system might be different where the patient is coming from. But in the end, it's a person living with ALS, and I think we all know what ALS means. We have the expertise. So it are mainly the practicalities that needs to be arranged. And one of those is the travel expenses. And the clinical trials that we are running, they do have third-party vendors that will cover those expenses, but also they will book the tickets, make sure that there is wheelchair accessible traveling, like either the plane or high-speed train. But it also, it's not only taking effort from us as a site, that third party, but also from the person living with ALS that travels from one country to another country. And therefore, it is important to pre-discuss, like either via phone or via a Teams call or Zoom, or what it means, like what do you have to offer as a site, but also what do you request from the person living with ALS. And of course, ethical approval needs to be obtained, and you need to make sure that the right insurance policies are in place. And I think with if you run an international clinical trial with which is pharma sponsored, they can help you through. So the clinical research organization or the CRO can help you guide you through that process. And it is important to discuss it within your hospital or within your clinic. What are the local policies? And contact with the referral center. So we are an international community, but it is important to know who is the referring neurologist. If there are any problems, if there are any adverse events, you want to do extra blood draws, that you have one point in the referral center that you can reach out to. And it is important to understand the differences in healthcare. Like in the Netherlands, we do not have Radicava approved, which is slightly different in Switzerland. So therefore, it is important to understand these differences in access to medications, but also how care is organized.
And just before we start talking about language, just to add to that, both Tommy and I wrote a standard operating procedure to facilitate the inclusion of international patients. So if anyone in the audience would be interested to set this up in their own center, we're more than happy to help. They come up with a lot of legal questions. So this is what you need to be prepared to answer. What if your patient has a car accident on his way to the airport in his home country, but he was going to come and see you in the other country? What if that car accident happens in your own country, they were coming to your site, or they were coming back from your site? Those are two different cases you need to anticipate. What if there's a side effect, but the side effect happens in their home country? So this can be a slow process to set up because sites are often scared about who will have to pay if anything happens. And that's the terrible reality of the things you have to anticipate when you set this up. And that once you get the conversation going and you've done your research, you know how to answer those questions. It's not a problem, but it can be a bit intimidating. At least it was for me when I had to read a lot of legal texts. So it just takes practice, so we'll be happy to support you with that. When it comes to the language, we divided it into main scenarios. Either you have a person with ALS coming to your site and everybody can speak English together. So maybe it's not your own mother tongue, it's not your patient's mother tongue, but you'll manage in English. You can read, understand, discuss in English. Same for your staff. Easy situation. Then ethically, you submit an information and consent form in English, it's approved. Then you have patient-facing document in English, it's approved. And then all of this gets on quite fairly easily. It gets a bit more tricky when a person living with ALS comes to you, does not speak English, only speaks one language that you do not speak, and nobody in your staff is able to communicate in that language. Then we usually partner with translation agencies. So either your hospital is able to provide one, and I'll let Peter and Tommy talk a bit more about this because that's what you guys are using. At our site, this is also what we do, but we also have partnerships with other companies, just because sometimes your hospital will tell you, yeah, I can translate over the phone. No, we're not doing a consent form review and discussion with someone on the phone with a delay. They don't hear you well. Can you repeat, please? No, we don't do that. But sometimes that's the only possibility that I have to offer. So it's then your role to kind of learn how to navigate in those situations. However, I would say this would be like a huge factor to consider, because that's where we can be flexible and stretch up to make the impossible possible. The language is kind of the last barrier that exists. I'm looking at you because I just, yeah, would you agree? Of saying this, this is the one thing you can't compromise on, is making sure the patient living in ALS who traveled to you understands 100% of the discussion happening, and vice versa. Can you understand their questions? Safety is not something you're going to be willing to compromise on. And this goes through language and communication. So this will be the one thing to really consider when setting this up. Did you want to talk a bit more about your translation?
I just want to briefly add, about the in-person translation. As you can imagine, doing a lumbar puncture or administrating a cognitive test is difficult if you don't speak the same language. So even for people that speak English sufficiently, or is their second language, it might be good to have an interpreter, especially during the first visit around. Also to get it, you need to build a relationship with each other. And luckily, communication is not only through language. And as I said, you know the disease. You are a center that is familiar with the disease. But it might be useful to have this interpreter either around the corner or in the room to not only understand each other with words, but also to give a level of comfort that that person is understood what he is saying.
Yeah.
May I just say you're running into your question time?
Okay, yeah. Just wanted to show this picture because this is our team together with Peter in Utrecht. And again, we are pretty pleased that we are now in Peter's home country. And now I give the floor to Peter.
Thank you very much for the invitation to speak here in Switzerland. You can be sure Switzerland is even smaller than Holland. And I became a frequent traveler with Swissair, participating the study in Utrecht. My name is Peter Ambühl, and I live in Switzerland, close to Zurich. I have a daughter. I'm married with Bettina, who is mostly coming with me when I have such dates. And my first ALS symptoms I had in February 18 while I was skiing in Zermatt. And then diagnosis was given in May 2019. At the moment, I'm somewhere around 37 points. In 2019, I was tested during the first examinations for the familiar genes with a negative result, and then it was done. You saw it on the screen before. And then I did quite a lot of research because I heard that there are people out there, ALS reversals, and then I saw an article about the mushroom for juvenile ALS possibility with a certain genetic setup. And then that motivated me to do genetic testing by myself because the insurance companies are not covering it normally until you find the right doctor who is writing the right letter, and then they take it over. It took approximately 6 months until I got the result that on the original testing it was negative. They couldn't find that I have this genetic testing, but they found out that I have autoxin gene repeat extension. And that was a surprise for me, but now I know I'm one of the 1 or 2 people living in Switzerland with this special genetic defect. And I was afterwards searching in the internet, what about the gene, and then I found this guy over there. And then I called him, and actually I wrote him an email if there is a possibility to attend this biogene study from Ionis. And then we talked at the phone, and then we figured out, can I travel? Yes, I can travel. Am I motivated? Yes, very motivated. And I said, yeah, could that be a cure for? And then with the explanation of Tommy, it was clear that it is a study and that I have the possibility to get probably a medicament who might work or not. A rule of the study, they told it before, I don't pay anything, so everything is paid by the sponsor. They organize from the traveling airplane to taxi to hotel to everything. I drive to the airport and that's it. And even, I think it's important, I am now since 1 year in Utrecht, 27 times. I was at the site in Utrecht, and we built up a close relationship, and that's very important because they are very friendly. I think they know what they do, as I'm still here. And that we reduced, I reduced with my visits with the team from St. Gallen to once every 6 months. Bettina normally comes with me. She's very important for me because she's helping me with the scooter I'm using. And to be honest, that's something really easy. You go to the airport, there's an assistant service, everything is booked. You go to the counter, you say, hey, I'm here, what do you need? Transportation to the airplane or whatever. And they are really friendly and they help you. With a 2-hour advance, when you're at the airport, it's no problem. And now I was traveling once a month to Utrecht. First we used the car and we visited on the way up all the friends, and then after a few visits, all the friends were visited, so we switched to the airplane, and that made it easier. The first visit was 6 hours, 6 or 7 hours, so we were obliged to travel the day before, stay overnight in a hotel, and the next day it was the 6-hour treatment. In the evening we flew back. Today it is 3 hours, 3 hours and a half treatment, so we figure out that's taking 7 o'clock in the morning the airplane, returning by 8. It's a long day, but it's, your next day a bit tired, but it's okay. And today I know that I get my study, or the study medication in the prolonged, how do you call it? The
open label extension.
Thank you very much. And that is announced to be going on till 2026. And today I'm looking forward to participate, travel once a month to Utrecht, and I'm using my scooter, and everything actually is going well. You told everything about the language. I'm up to learn a bit Dutch. I hope you learn a bit Swiss German for me. And for me, the situation it became with the discussion about the research, with the discussion about what's going on, I feel like being a bit more important in the whole family, that I can give something to the community, even probably if I don't get the right study medication. I know that I have this gene repeat extension, which is quite rare, and I have 4 points to the audience. Genetic testing, it's really, really important, because I'm 1 or 2 ALS patients are living with my gene mutation in Switzerland. So who the hell is going to find them? So if we would like to have a medicine who will become quick on the market, we have to make those studies run efficiently through the process. And the second thing, I think the national institutions, the clinics, should really make attention to the patients, that there is a possibility to attend internationally in studies. As I'm missing it a bit in the association here, that they take extremely well care about the patients, but the study could be more motivated. And then the fourth thing, patients should know about the possibilities that they can as well register in international databases like TRICALS, that somebody else can find them even if the medical doctor in their home country is not offering the service. And I'm personally really, really proud that I'm here, that I can participate, and now I see the lady in the back. Bang, bang, bang. Thanks a lot. Have a great day in Switzerland, and see you soon. Thanks.
Peter, Tommy, and Juliet, thank you so much for a fascinating perspective. And I think you really highlighted some of the challenges of the international trials. But thank you for your participation and your presentation.
And
thank you.
Come to us if you have questions at a later time.
So, moving swiftly, whoops, to the edge of the stage. Yeah, fantastic. Good. Nothing to see here. So next I'd like to welcome Milena Contreras there you are, thank you, for your talk on cognition, behavior and decision making in MND ALS.
Short, so just gonna fix this for me. So thank you very much for having me. So it's great to see that you've already been discussing a bit about cognition. So it is important to study decision-making in people living with ALS because, as you all know by now, this is a spectrum disease that ranges from 50% of the cases that only present motor symptoms to around 15% of the cases that end up developing ALS frontotemporal dementia. There's also, in this spectrum, around 35% of the cases that develop some milder changes in their cognition and or behavior. However, it is currently unknown whether these changes can have an impact on the person's decision-making and mental capacity. In relation to the changes in behavior that some people with ALS may experience, it's including socially inappropriate behavior such as disinhibition, apathy, which is a lack of motivation, loss of sympathy, empathy, and people perhaps start becoming a bit more self-centered or just showing a disregard for other people's needs or distress, and also some changes in eating behaviors such as binge eating and over-drinking or excessive craving of sweet food. In terms of the changes in cognition, some people might develop language dysfunction, which can include problems with naming or spelling. There might also be some social cognition impairment, which is a difficulty to understand how other people think or how other people feel, and some executive dysfunction, which are higher order functions of organization, planning, attention, and decision-making. So people with ALS need to make important decisions throughout the course of the disease that can have a great impact on their quality of life. We conducted a focus group at the University of Edinburgh, and we found out that the type of decisions that they had to make were, from the very beginning, for example, who should I tell about the diagnosis? Should I stop working, go on holidays? Where should I live? Do I need to make any adaptations to my house? Should I bank my bows? Should I get a wheelchair? Should I join a clinical trial? There are also, I'm too short, so I'm just trying to look at the, look at the screen here. Also, particular decisions about treatments such as ventilation or feeding tube, and finally decisions about end-of-life care. Mental capacity is a legal term, and it's the ability to decide, to make a specific decision at a specific time in a specific situation. So we cannot say that someone has mental capacity or that someone doesn't have mental capacity, full stop. This is something that needs to be considered in a particular context. So in the UK, we have the Mental Capacity Act, and it says that you should assume that someone has mental capacity unless it's proved otherwise. So to say that someone has mental capacity, you should consider the following 4 components. First of all, you should consider that they're able to understand and retain the information you provide, that they're able to use and weigh up this information, which is basically identifying pros and cons. This is also known as reasoning. And finally, that they're able to communicate their decision. So we know from research conducted in people with other neurological conditions that the cognitive and behavioral impairments could affect how well someone performs on a mental capacity assessment. And for example, language dysfunction could affect how people understand and communicate information that is relevant to their decision. Executive dysfunction could affect attention and also could affect how people are able to retain the information we provide to them, but also could affect how people consider the consequences of their actions. Deficits in social cognition can affect how people consider the consequences of their actions on other people, such as their loved ones. And finally, apathy could affect all the components of the mental capacity assessment if the person doesn't have the motivation to undertake the assessment, or if they are unable to generate new ideas or responses to our questions. So now I would like to share with you some of the results of a study that I will be presenting tomorrow at the MNDA symposium. So COG15 is the number of the poster. It looks like the name of a gene or something, but no, that's the name of the poster. And this is a study funded by MND Scotland on mental capacity to make treatment decisions in MND. So we look at exploring if mental capacity to consent to medical treatments, in particular a gastrostomy or feeding tube, was affected in people with MND. We also wanted to assess if their performance in mental capacity assessment could improve with appropriate support. And finally, we wanted to investigate the relationship between mental capacity and cognitive impairment. To achieve this, I interviewed 21 people with MND and 14 controls. These controls were matched in age, gender, and education. They all completed an adapted version of the MCAT-T, which is a tool to assess mental capacity to consent to a gastrostomy. And we also asked them to complete an ECAS to measure their cognition and their behavior. So from these 21 participants with MND, 16 of them also completed a repeated version of the assessment of their mental capacity, but the second time we used some support strategies. So the information that they received, it was exactly the same content, but this time it was presented with some images. We also made some changes to the way we were asking the questions so they could be more specific rather than general and open questions. And we also asked them to complete a comparison table so they could consider the consequences of each action. But I will discuss the support a little later. So in terms of preliminary findings, so this figure shows the main differences in mental capacity components between people with MND and controls. So what we found is that the MND group performed significantly worse than the control group in the components of understanding and retention, also in the component of reasoning, which is the weighing up of information that I mentioned before, and also in the total mental capacity score. So from the 21 participants, 3 had impairment in understanding and retention, 6 presented impairment in reasoning, and 3 in both. So that's a total of 12 participants that had difficulties with the mental capacity assessment and that they should be probably classified as impaired mental capacity. In terms of cognition, 6 participants out of 21 were classified as ALS with cognitive impairment. 5 out of 15 had behavioral impairment, and 3 out of 15 had both cognitive and behavioral impairment. So for reporting the behaviors, we asked a study partner, which was in most cases a relative or a friend, to provide information about these behaviors, but not all the participants had a study partner. So that's why it says 15 rather than 21. So now, Does cognitive impairment predict mental capacity? Well, because of the small sample size, we couldn't perform a regression analysis. But what we found is that from the 12 participants that had mental capacity impairment, 6 of them also had cognitive impairment. There are also other factors that could affect how people perform in the mental capacity assessment. For example, behavioral impairment, which is something that we didn't consider in this particular study. And there was also something that we didn't measure quantitatively, but it was coming up quite frequently during the interviews that I conducted with them. And that was the emotional component of having to make these treatment decisions. So that's something that perhaps could also affect how people perform in the mental capacity assessment. Now, looking at the mean differences in mental capacity without and with support in people with MND. So this is intra-subject. It's the same people that perform the assessment twice. We found that the use of support strategies during the mental capacity assessment significantly increased the performance of people with MND in the task, and there was a particular significant improvement in the score of understanding and retention and reasoning. So in summary, these preliminary findings suggest that some people with MND have problems in decision-making and may lack the capacity to make specific treatment decisions. As I mentioned, mental capacity, it is very specific to the decision and to the time that we are conducting the assessment. When compared to controls, people with MND perform significantly worse in cognitive and mental capacity assessments. There were also 50% of the participants who failed the mental capacity assessment that were classified as ALS with cognitive impairment, as determined by the ECAS. As I mentioned, there might be other reasons explaining why people perform like that in this assessment, and we hypothesize that this could be due to the apathy, for example, or behavioral impairment, and also due to the emotional impact that it has having to make these treatment decisions. Finally, appropriate support strategies may enhance overall mental capacity in people with MND, in particular the ability to understand, retain, and weigh up information. So I would like to finish this presentation by giving all the healthcare professionals here today, and also those that are seeing the streaming, just to give you some recommendations for supporting people living with ALS when making decisions. These are all based, like in this treatment decisions, but I think that some of them could also be applied to other contexts. In terms of supporting the understanding and retention of information, we recommend to ensure that the information is written clearly and in lay terms. This seems quite obvious, but sometimes for specialists, they are so used to certain type of information, they think that it's clear, but it's not. Also, it's recommended to present it in short and bulleted or number paragraphs, and to include images of how, for example, if it's a treatment, how does it look like in someone that has the treatment, or cartoons, something that could facilitate the understanding of abstract or specific information. It's also recommended to include information about alternative options as the consequences of making no decision when possible. It's also recommended to be as honest as possible with the risks of certain treatments, or like the negative consequences of choosing determined treatments, for example. And also provide the information in advance so the person can read it before the appointment and as many times as needed, because this will give the person more time to understand the information, to digest it, and also to think about questions that they might want to ask in the next appointment. And use short and specific questions and or prompts if the person struggles to answer broad questions. However, it's important to be careful with the type of prompts that we give, because you don't want to influence the person's responses. And also, it's something very important to leave aside our own personal or moral judgments about certain things, because at the end of the day, we are just there trying to support the person making an autonomous and a decision, and an informed decision that should be based on their own values rather than ours. Also, for supporting the weighing up of information, this is something that we did, and it was proved to be very beneficial to let the person making the decision complete a pros and cons table to help them compare the available options and test their ability to use the information provided. So, for example, in our study, we asked them to complete a table where they were comparing having the gastrostomy tube and not having the treatment. And we use these specific categories, for example, health benefits and advantages, health risks or disadvantages or complications, positive and negative impact of their decision on their everyday activities or everyday life, and also the positive and negative impact of their decision on their relatives or loved ones. So in our study, we would start for their preferred option. Let's say that if they were favoring having the treatment, we would begin for that option, go over all these categories, and then move on to the next one. Finally, for supporting the communication of the decision, it's important to take into account the communication needs of the individual, particularly those with bulbar onset ALS, and consider involving the carer or a relative or any other professional who can assist you, as long as they can be objective and, again, not influence the person making the decision. It's also recommended to give time to discuss the information relevant to the decision they need to make, and this might require discussing the decision in more than one opportunity and appointment. And finally, be patient. This is very important. Be empathetic and consider the emotional implications for the person making that decision. So in our study, we found that deciding if they wanted to have the treatment or not, it was seen as some people as a decision about wanting to prolong life or not, and under which conditions. For other people, accepting having the gastrostomy was like a realization that they were in the late stages of the disease or near the end of life. So for this reason, people try to delay the decision for as long as possible. So yeah, in general, just consider that as well. Thank you very much. So as I mentioned, I will be presenting my poster tomorrow if you want to discuss more of that. And that's my lovely group with Professor Sharon Abrahams. Thank you to all the participants and to Emily Scotland for funding the study. Thank you.
Thank you, Milena, for such an important talk. I think people living with MND have so many choices and decisions to make throughout their journey. You've given some very practical ideas and thoughts for that. You have one question? You have no question? There is a question here in the room, but while the microphone's going, I was thinking, is there times when you've had to think about person's best interest and actually all of your strategies might not have kind of helped completely and you've had to make decisions in somebody's best interest?
So in most of the participants we had, they performed worse in mental capacity in the mental capacity assessment, and they also had impairments in certain components of the mental capacity assessment, but they were able to answer all the questions. Yeah. So there was no need to use like a welfare attorney or how you call it in England. I'm thinking about how you call it in Scotland, or a consultee. Yeah. So they were able, but basically this study is to show that with certain support, people might be able to make these decisions autonomously, and perhaps there's no need to include someone else to consent on their behalf. But again, there might be some people with a more severe FTD that in those cases, perhaps, yeah, it's needed to include someone else.
Thank you. I think that's very valuable. You have one question?
Thank you so much. Do you have recommendation and screening tools? I mean, you can do long testing, but is anything that you can give in 5 minutes and say, okay, you have to have further testing and you're okay? Can you have screening tools? And the second is, if this is progressive, do you have tools that you can repeat at a later time to see if the cognition of the capacity has changed over time? Let's say 6 months later, a year later, can you repeat the same test? Do you have anything to measure progression in terms of cognition?
That's a really good question. In terms of cognition, yes, there are many tools, like the ECAS, for example. But in terms of mental capacity, I think it's important to mention that a lot of people, they think that mental capacity and cognition are synonyms, and if they do well at a cognitive assessment, then they don't have mental capacity problems. And what this study is showing is that people that have mental capacity impairment might be for other reasons, not only cognitive impairment. So ideally, I know that depending on which country are you in, but ideally psychologists, clinical psychologists, neuropsychologists should, if you have some concerns, could undertake a mental capacity assessment. It's more like a clinical interview. But it's basically to be able to test that the person is able to understand, retain, and weigh up this information and communicate their decision. And that's something that you can repeat more than once. But I think it's about finding the balance, because as I mentioned, at least in the UK, you should assume that the person has mental capacity unless it's proved otherwise. So it's tricky, but that's why we think that perhaps with this kind of support strategies that any kind of healthcare professional can use, perhaps that could help people with their decisions.
Good. Thank you very much. Thank you.
Thank you.
Thank you. Next, please welcome to the stage Matthias Couliard and Vanessa Bunte. Oh, it's you two. In disguise.
We have to lie about our names to talk a third time. No, I swear it's the last time you see my face this morning on stage. You'll have to bear with Tommy for another talk. But this talk this morning is really tying up and linked to the previous two talks we already gave. It really ties to the work Tommy and I are doing under the umbrella of INARC, the International Network for ALS Research and Care. So INARC was created now soon to be 2 years ago, and really started from the realization that we needed a specific network for staff members involved either in research or in clinic or in both, and for staff members who are not doctors, because doctors already have a seat at the table, and not so much so for OT, PT, SLP, research nurses, assistant nurses as well, doing a lot of data collection. So we wanted to kind of create a network specifically to address these needs. And when it comes to intersection between ALS care and research, we really see it as a continuum. And this is the case usually in the biggest clinics or the biggest sites working on ALS, not so much for the smallest sites because the realities are different. So that's what we're gonna talk to you about. And so we're filling up the shoes of Matthias and Vanessa, who couldn't make it today, but we're also working on this with Corey Straub and Romy Verschoor. So it's an effort that 6 people are invested in. So when it comes to, and you know this better than I do, but when it comes to multidisciplinary clinic care and research, it's been associated and proven to be associated with longer survival time for people living with ALS. So this is becoming the gold standard. However, we still meet people living with ALS who are followed by a neurologist, not specialized in ALS, that they may see once a year. So it is still, even though we know it brings many benefits to the table, we know this is not the standard for many patients out there. It improves quality of life, and it does mean that as a patient, you will meet several key players. You will meet people with very different expertise. I feel like we've talked about experts and expertise this morning quite a lot, and this is really tying up when it comes to clinical care in a multidisciplinary setting. This also comes into play in research. We've heard talks, and we will hear talks in the week about people with very different specialties within research, within the ALS field. So the idea behind this intersection is how one can feed from the other and vice versa. We know that some amazing projects have stemmed from nurses who observed something they found curious, weird, intriguing in clinic, and that has stemmed into people with a very clinic profile into leading up with research projects. So this is what we want to highlight here. This is a figure that is kind of showing this intersection that is true both for patients but also caregivers and how they intersect with general practitioners, but also PT, OT, rehab. I know in the Netherlands they have specific rehab doctors. We don't have that in Sweden, but this is, again, very country specific. And what I would highlight in this team approach is that there is also a huge teaming up with the entire support network of the people living with ALS that you're working with. And that's for you.
So as Julia introduced INARC to you, we had our first meeting organized also by Ursula in Barcelona in 2023, and we had 13 countries represented with 21 sites, and there was like quite a variation amongst like larger sites, smaller sites, and also composition of the team. So we asked like prior to the people attending the meeting, like, what does your team have? Like, how many people does your team have? And we created it here, a slide like, and these are the numbers on research staff. So it could be vary from observational trials, interventional trials, but just to give an idea, like how many people are working on clinical trials in ALS. This is not only across Europe because Canada was present as well. And you see there's quite a number of variation, but despite this variation, I think it's important if you work with people living with ALS, whether you like deliver care or you focus on research. Since we do not have like a treatment for the disease, it is important that you know that research is out there and is needed to find a solution and a cure for the disease. So if you are a care nurse and you consult with your patient and your patient is not participating into a clinical trial, but your patient is willing to participate into the clinical trial, it's not necessarily that you need to execute that trial, but at least know the members in your team, but also linked to the previous presentation, know other hospitals near you that run clinical trials and know that who you should reach out to fulfill that unmet need of finding a treatment for this disease.
So what we did, one of the things we did this summer in Barcelona at the INARC meeting is that we sent a questionnaire to the participants before the meeting was held, and we asked them, is clinical practice and research combined at your site? And the majority, 58% of the participants answered yes. And we were curious, we were talking with Tommy this morning when we were rehearsing our slides, and we were curious, by a show of hand, could you raise your hand if in your clinic or in your work setting you're combining research and care? Yeah, I would say it looks like 58% to me. So this is interesting because as you talk with people coming from very different settings, you realize their realities are very different. They're not funded in the same way. Sometimes when, especially with smaller sites, your nurse has to also be a medical secretary and pull out admin work and pull out a lot of nursing duties, but she's also helping on the clinical trials, and then she's also handling the phone, and so this, of course, multitasking does not allow you to nurture research projects. So this is also very, it reflects a lot of the realities of the site. An example that we wanted to share with you is something that was shared at the last INARC meeting is, so the spiritual care counselor, not something we're all very familiar with, so spiritual care counselor, not associated with any religion, not a psychologist, but here to support people with ALS, their families, but also the staff with spiritual needs. From the Montreal clinic in Canada, she joined as a purely clinic staff member working for the clinic. And as she was reading on mindfulness, as she was reading on the spiritual care literature, she decided to apply for a research project. And now in Montreal, they're doing this mindfulness research project that they have implemented in their clinic with their patients. And that was, I think, a good example of how a clinical team member who may not think of research in their daily practice, they saw a problem and they were thinking of, how can I address this? How can I fix it? How can I implement things to make it change, or at least to better understand the margin of the problem? And I think that was a good example. And we see this happen, but we also need to acknowledge that it can flourish in an environment that allows you to do so. And when we talk about intertwining research and care, it comes with quite a lot of pros and cons. If I take the good side of things, and I'll leave the bad side to Tommy, the strength of merging care and research are that you're working with a shared knowledge, so everybody's expertise can feed the everybody's projects. You are already on site with the people you need to interact with, so it's very easy to collaborate. If you're a PT but you want to start a project collaborating with SLP, usually you're a corridor away, so it's quite easy to stem those new research projects. The accessibility of the care is going to be quite easy. You don't have to have transportation for, let's say you're working with the same person with ALS and you want to do a multidisciplinary research care project. They can see everyone at the same time, at the same place, and that's a huge plus. Patients already have this trust and this bond with the people they usually see in clinic when they now see them in research, or vice versa, even though we see that less likely. And so that's a huge bonus when it comes to then presenting the research, and they would usually feel more comfortable asking you super blunt questions instead of creating this relationship from the ground up. And then, as we see it, as we discussed within INARC members, we see it as really reducing the patient burden, this collaboration. They usually, what was brought back to us is that there was a sense of safety, of being handled by the same people, both for research and care, because they had the feeling that it was one same team taking care of them for all of the aspects of their disease, either the clinical management or the research they wanted to do. You want to go with the bad stuff? If there's such thing.
See who will deliver better. No, I will just discuss with you like potential limitations, because there is not one size fits all. Like the visits might get longer, but it also will if you have some creativity, like for example, if you administer the ALS-FRSR, if you perform neurological examination, you can do that at once for the clinical, for if a patient is participating in an interventional study, please make sure that that rater is certified and is the same person over the course of the clinical trial. But like this information that you gather once during that day can be transported into research. And I don't think like research nurses or research staff are ticking boxes on the ALS-FRSR. Oh, okay. Oh, you lost more than 10% weight. Oh, you have excess saliva. Tick box. There are actions coming out of these like results. So I think at least that's how it is working in our clinic. Like I'm fully focused on the clinical trials, but I have a close link with our clinical care team, that if I have a person with excess saliva, or we weigh that person, we see there is weight loss due to dysphagia, I can just run one floor down and say, oh, hey, can you just inform this person about a gastrostomy? Or I can just at least start the conversation. But it are longer visits, so requires maybe facility, like your facility, if your facility have beds available so people can rest, that might help it. And all personnel that is in the multidisciplinary team, that might be slightly difficult to have them all available at all times. So I think it's important to have everyone in your team at least have a sense of what the other team member is delivering. Like, you do not need to give that full explanation, but at least like maybe tell the patient, I heard about like this, I can refer you to, or I know what a gastrostomy is. Did anyone talk with you about it? If not, I'm happy to make an appointment to get more information. And it can be slightly more costly as like the visits get longer, but it can also be, I think, more cost efficient because like you do not have your person living with ALS come into your clinic like every 2 to 3 weeks. It can be a limited number of visits. And it's not always easy to solve the issues within research. Like different clinics have different setups. So there are some hospitals that have like a clinical research wing, and at one day the nurse will see people with cancer in research, and the other day they see people with MND. So therefore, if you do this setup, if you do this merging with ALS and care and research, might be important to have some dedicated staff that is able to understand what is the cause of the disease, what comes with the disease, and not only like doing the slow vital capacity, ticking the boxes on the ALS FRSR, but also knowing what are the consequences of the outcome of the ALS FRSR, for example.
And one thing I'd just like to add to that is that the worst case scenario I could think of when it comes to intersection between care and research. Of course, the goal is not for all of you clinic staff members to come back home and say, I'll start research projects. That's not realistic. However, the worst case scenario would be for a research staff to meet a patient seen in the clinic of your site. And they have seen neurologists, they have seen nurses, they have seen other staff members, and nobody told them about trials. Or the nurses from your clinic have no idea about the clinical trials your site is offering. That would be the worst case scenario, because then, first of all, you can't collaborate with your clinic team by asking them, hey, by the way, do you know what I'm doing right now, trial-wise? And we're talking about intervention now. It can be other, like observational research projects. But for clinical trials, when you have that strong sense of collaboration and of continuity, a nurse will be able to, when they meet patients, think, that patient may actually qualify for the trial our site is doing. I'll flag that patient to the research team. So this also needs to be really seen as a whole. And same, when you're going to see a person living with ALS for a clinical trial, you're going to see them much more often than the clinic members. So you'll also be able to flag back things you've noticed, or progression, or updates that you may have missed otherwise.
Just watch that wire while you're... So Matthias and Vanessa, aka Tommy and Juliet, thank you very much for your presentation. Do you have any questions in the room? Any questions? Oh, Sarah.
I'll take the online microphone. So we do a lot of these similar things. We do have, of course, we do kind of a pre-screening of the people coming into the clinic to determine who might meet with the research. We do merge their clinic visits when they match up at the same time. We don't merge all of them, but say they're coming back for a particular visit. My question, though, is when you said it more costly, because if they're a research trial patient, they don't get charged for any of the care.
What you have to avoid is that the care that you're delivering will become to charge for the research project that you are doing. So, and vice versa. So what you want to avoid is that you're delivering care under the research project, and that, or you do research under the care project. That's what you want to avoid.
So just to give you guys an idea, we have a research visit in the chart, and then we'll have the multi-disc. And if anything is duplicated, it can't be charged to their insurance. It has to be charged to the
And I think that's
study.
That's for the majority of the country. That's also happening in our country. But you just need to make you need to be aware of that is existing, that you don't either double book or that you do like as a yeah.
Lovely, thank you. I think we'll leave that there. Thank you, Julia and Tommy. Tommy is going to stay here now, and I'm just going to invite Gail Kittle to the stage. Thank you. And they're going to present ALS-FRS-R, and I can't say this word, harmonization session. Thank you.
Hi, everybody. You've met Tommy already. I'm Gail Kittle. I'm from Barrow Neurological Institute in the United States, and I do a lot of the training for ALS clinical trials for the outcome measures including ALS-FRS-R, vital capacity, and muscle strength testing. Did you want to add anything about you? Okay, great.
Yeah, you know me already, but besides like doing clinical trials, I'm also delivering like training sessions for under the TRICALS flag.
So we were asked to provide a high-level overview of some changes that recently occurred regarding the ALS-FRS-R that we're going to talk about. But first, I just wanted to give you a little bit of background about the scale in case you're not familiar with it. The ALS Functional Rating Scale Revised is a commonly used questionnaire almost in any late-stage clinical trial. It's almost always either the primary outcome measure or secondary outcome measure. It's a 12-item scale measuring the performance of daily activities. The scale is divided into 4 functional groups, including 3 questions addressing bulbar function, 3 questions addressing fine motor function, and 3 questions addressing gross motor function, as well as 3 questions addressing respiratory function. So each question is scored on a scale of 0 to 4, and 0 means that there's really no function in on that question, to 4, which is normal function as compared to prior to ALS. So in research studies, the evaluator who is administering the scale always needs to be certified, which means they've been trained and passed reliability testing to receive their certificate. And Tommy and I primarily have done that training historically. So as I said, Tommy and I provide most of the training on the scale. Tommy on behalf of the NCALS TRICALS European group, and myself on behalf of the BNI NEALS group in North America. Many evaluators who are conducting this assessment, depending on what studies they're working on, may have been certified by both our entities, by both TRICALS and NEALS groups. And over the years, we have become aware of significant differences in the guidances that were provided for scoring the ALS-FRS-R between the NEALS and the TRICALS group. So this was becoming problematic, confusing evaluators who were certified on both NEALS and TRICALS, and the certificates were not interchangeable at that time. So over the past year and a half, the 2 entities came together, Dr. Jeremy Scheffner and myself from NEALS, and then Dr. Leonard Vandenberg and Tommy on behalf of TriCals, and then Angela Genge was also very involved in kind of facilitating this whole project. So what we're going to do now is just provide just a high-level overview of the differences in scoring between this harmonized version that we're now working with, where we have come together and harmonized the guidance. So we are calling that the harmonized ALS FRS. Everything that we're providing to you today, it has been published recently in a research article in the ALS and FTD journal, and either Tommy and I are, if you reach out, are happy to provide you a copy of that. So everything is there, the new SOP as well as the differences that we're going to highlight. So, Tommy, do you want to start with the bulbar questions and just...
Yeah, so how we continue, Gail and I, is like we will present you the 12 items on the ALS FRSR, and on the table below or on the table on the next page, depending on the amount of differences, we have highlighted which scoring was variating the most. This doesn't account for training. It's well like a high-level overview on like what are the differences.
Yes, be relieved, there's no training.
Yeah, so here you will see like the first question on speech. So we thought initially on TriCals to do things slightly differently, and later that caused problems. So we solved that problems, luckily. In the item number 2, intelligible with repeating, so if a patient was rated 2 under the new standard operating procedure, that was defined as some repetition required to understand speech in daily conversations. Whereas under the TriCal standard operating procedure, we thought it was a good idea to incorporate a cutoff of more than 25% of the time. It didn't turn out to work pretty well, so we harmonized it into the word significant. So if the person living with ALS need to repeat him or herself with significant repetition into a normal conversation, so not at a party, then the person will be rated a 2 on this item. Same we did for salivation. The TriCal standard operating procedure continue with using the cutoff of 25% of the time for moderately excess saliva or have minimal drooling. So we defined that if there is more than 25% of the time a tissue needed, or if there is more than 25% of the time drooling present, then a patient will be rated a 2 under the TriCal's SOP, whereas under the NEALS SOP, it was occasionally dabbing around the mouth. Wording might be similar, just slight differences in interpretation, and we harmonized that into the updated SOP as occasionally dabbing into of the mouth with a tissue during the day. There was also some differences on item number 3, so slight but definite excess saliva in the mouth and may have nighttime drooling. So under the TriCal's SOP, that was with or without nighttime drooling. That meant that there is an excess saliva, but no need to mop up. And under the NEALS SOP, it was phrased as swallowing more frequently. So again, maybe just it seems to you, if we present it right now, just minimal differences, but it would have been, or it could have been occurred that if you use the TriCal's SOP and the NEALS SOP, that there is variation in scoring, and therefore you might not find the potential treatment effect. So that's what we wanted to avoid, and therefore harmonized it into some excess saliva, but no need to mop up on item number 3. And the last item in the bulbar section is swallowing. And we had some differences here on item 2, 3, 2, and 1, which the main differences between item number 3 and number 2 were the consistency, whereas under the NEALS standard operating procedure, it's like if people needed to cut food up, people will be rated a 3, whereas under the TRICALS SOP, it's stated as like the food needed to be liquidized. And we had some additional criteria in the TRICALS standard operating procedure for people who not have a gastrostomy but needed one. So, and we harmonized that into the significant weight loss, or people that cannot maintain their own weight by their oral intake due to swallowing difficulties. So that will rule out people with only atrophy and no bobber involvement. And we harmonized item number 2, the dietary consistency changes, whereas if people either avoiding food or the food needs to be cut up into smaller pieces to be able to swallow, then people will be rated a 2 and a 3 if they have early eating problems and there's only coughing or it stays sticky in the throat, but there are no other changes there.
Okay, and then I'm going to talk about summarize the changes in the fine motor function section. Starting with handwriting, really, we were very much aligned on the guidance. Maybe some things were worded a little bit differently, but the guidance was identical between the two, so there was no change there. There was some changes in cutting food and handling utensils. This would be 5A for patients who do not have a feeding tube or do have a feeding tube but don't use it for their primary method of caloric intake. So, for a rating of 3, somewhat slow and clumsy but no help needed. The major difference here between the Neels and the TRICALS was that for Neels there was just some difficulty cutting utensils, but they were still independent and not using altered utensils, so adaptive tableware or silverware. Whereas for the TRICALS guidance that if they could still be rated a 3 if they were using adaptive silverware of any kind. We did harmonize this that there is some difficulty either cutting food or holding utensils, but they're able to do this independently. So we took if they're using adaptive tableware, that would be a form of assistance, so they're not independent. So a 2 is where they are now using adaptive tableware to help them. So we also did some clarification in question 2 where they can cut most foods, although slow and clumsy, but some help is needed. It mostly boiled down to how much they were able to cut their foods. And we harmonized this into needing occasional assistance for cutting food, but being independent for the task otherwise. Whereas a rating of 1, where food must be cut by someone but can still feed slowly, again, there was some differences in the level of cutting and assistance that was needed for cutting. So we have harmonized this into assistance is required at least half the time for cutting, but not for feeding. And it just seems like it's very much more straightforward with the harmonized guidance. There's no change in the rating for those patients who do have a feeding tube and do use it for the majority of their nutrition. And then for dressing and hygiene, so for Neels, a rating of a 2, where they needed intermittent assistance or substitute methods. Basically, we said that they were making modifications, but they were not requiring any caregiver assistance, whereas the TRICAL guidance said that they could be receiving intermittent assistance from either a caregiver or the modifications, so they were involving a caregiver. So our harmonized scoring is that they are now using methods different than prior to disease onset, and that minimal help is needed either from a caregiver or use of assistive devices. So the minimal help from a caregiver or occasional assistance from a caregiver is used for the harmonized. And then on one needing an attendant for self-care, the NEALS guidance was that this means daily caregiver assistance with dressing, but the patient has some level of function, while TRICALS was saying that this means that all aspects of the task require assistance, but the patient is able to assist the caregiver. So very similar, and so this is harmonized into both dressing and hygiene activities require a significant level of caregiver assistance, but the patient is able to assist the caregiver. So that would be for I believe that is for the fine motor movement. Tommy will talk about gross motor movement.
And we were consistent on item number 7, turning a bed and adjusting the bedclothes. Similar for item number 8, walking. There might be have like different wording, but it didn't impact the scoring under either the NEALS SOP or the TRICALS SOP. And similar for climbing stairs, we were consistent here. Again, wording might have been used differently, but from an outcomes perspective, it didn't change the scoring.
And then on the respiratory questions, on question 10, where we asked about dyspnea or shortness of breath, this probably had the most major discrepancy in the scoring guidance that could result in a scoring difference of 4 points, depending on which scale that you were using. So when we ask about breathlessness, if you were rating by the NEALS SOP that if a person was using any form of non-invasive ventilation, you were to ask and score by their shortness of breath during the times when they were not using the non-invasive ventilation. So if you had a patient who was using BiPAP at night but not during the day and did not have shortness of breath during the day, they could be scored a 4 because they were not having any shortness of breath when the NIV was not being used. For the TRICALS guidance, if someone was using assisted ventilation during the night or day for ALS, they were to be scored a 0 automatically because they were using that. So that same person could be a 0 on the TRICALS scoring. So after we discussed this, we decided that the harmonized version would be to rate them by when they are not using their non-invasive ventilation. So that would be the harmonized guidance for question 10, and then there really were no inconsistencies with orthopnea or respiratory insufficiency.
Could you not get enough of Gil and myself? Tomorrow we will have a training session on ALS FSR harmonized slow vital capacity and HHD in the conference center, followed by drinks.
Okay, and that was what time? And where? What time and
Sorry,
where?
from 6 in the conference center.
Okay.
Thank
Thank you, Tommy and Gail,
Yeah.
for your presentation. I think harmonization, I said it, harmonization can only be a good thing. So thank you for that. But interestingly, from a different perspective, I've just had a text from a patient who's watching online, and they said that the ALS SRF, from their perspective, doesn't feel like a useful tool and a useful thing from their perspective. But I know why we do it, but it's considering the patient's thoughts too. Is there any questions from the audience? Yes, there's one Richard has.
Thank you. I'm going to group the questions together. So hang on a second. This is from Lynn, ALS Problem Solvers. ALS FSR is an okay measure for lower motor neuron function, but is it a poor evaluator of upper motor neuron involvement? And how is, this is from Kevin Robinson at NEALS, how is salivation evaluated if medication is used to manage? And on a linked one is, which medication to use for excessive salivation? Scopoderm is practically unavailable in Switzerland.
We will break it up. So I will do the first one about the upper motor neuron. So, and it has been said, the ALS-FRSR also in the comment that Rachel gave or reflected by the patient online, yes, the ALS-FRSR has a lot of limitations. And I only think that currently with this outcome measure, or with the ALS-FRSR being the primary outcome measure or the secondary outcome measure in the majority of the clinical trials, that's because we do not have an other outcome measure that, like with the heterogeneity of the disease, capture or is able to capture change for people with the variety of symptoms. And yes, indeed, like it's more of a lower motor neuron scale. However, on the first item on bulbar, like people can have a pseudobulbar effect, which can be reflected in, or will be reflected in the ALS-FRSR, same as stiffness, like that will reflect in like dressing or washing difficulties, walking difficulties, turning in bed difficulties. So although it seems on at first hand that upper motor neuron is not, or the most of the questions do not capture upper motor neuron. However, if you look into every item there, it will be reflected somehow.
And there are a variety of outcome measures that are under investigation now, including biomarker outcome measures such as neurofilament, which I'm sure we'll hear a lot about in the bigger symposium. So as far as salivation goes, and this is in publicized in the SOP and the guidance, that the patient is to be rated on their level of salivation regardless of whether they're on medication for salivation. So this one could fluctuate depending on how well their medication is working, but if they are taking medication for excess salivation, they should be based on how they are doing on that medication. So, and then it's really not within the scope of the scale to determine which medication is the better treatment.
So Tommy and Gail, I wanted to thank you. I have a thumbs up for Tommy, for my patient. It just says thank you for the answer. So maybe thank you, Tommy and Gail. So this brings the end of our session, and it's now lunchtime, which has kindly been sponsored by Zambon, so we are very grateful for that. So if you're virtual, please step away from the computer and go and find yourself some lunch. For everybody else who's in the room, there's a very lovely lunch outside, and if you can be back here for 1:50, we'll be very grateful. Thank you.